Hey everyone, and welcome back to the Deep Dives. You know we love diving deep into all sorts of healthcare topics, but today we're doing something a little different.
Different how so?
Well, today's deep dive is tailor-made, just for all you future nurses out there.
Focusing on the up-and-coming generation of healthcare heroes. Love it. What crucial topic are we tackling today?
Airway management.
Now, that's a topic every nursing student needs to master. Truly the bedrock of critical care nursing.
Absolutely. I mean, think about it. If someone can't breathe, well, nothing else really matters, right?
Couldn't agree more. It's fundamental.
So to help us break it all down, we've got a stack of excerpts from nursing school curriculums, some recent journal articles, and even a few real-life case studies to spice things up.
Sounds like we're well equipped for this deep dive.
Oh, we are. Think of this as your airway management survival guide, but a lot more exciting than those massive textbooks.
We'll try our best to make it relevant and engaging.
Oh, it'll be engaging. Trust me. So let's jump right in with the superstar of airway management. The endotracheal tube, better known as
The ETT.
the one and only. I'm sure you've all seen these in action, maybe even had to help with a few during clinicals.
Oh, yeah. They're pretty much everywhere in critical care settings.
For sure. But have you ever stopped to think about the WHY behind an ETT? Why would someone need one in the first place? It's not just for decoration, right?
Absolutely not. There are two main reasons a patient might require an ETT.
Okay, hit me with reason number one.
Airway compromise. Imagine a patient with severe pneumonia. Their lungs are so inflamed, filled with fluid, they can barely expand to take in oxygen.
It's like trying to breathe through a wet sponge, isn't it?
Exactly. So the ETT provides a clear pathway for air to bypass any of those obstructions and get straight to the lungs.
It's like building a detour around a traffic jam, but for air.
Now that's a great analogy.
Okay, what about reason number two? Why else would someone need an ETT?
Protection during surgery. Think general anesthesia. It basically paralyzes your respiratory muscles.
Oh, wow. Yeah, I remember that from A&P class.
Right. So to prevent aspiration and ensure the patient is getting enough oxygen during the procedure, an ETT is crucial. It lets the anesthesiologist control breathing and keep that airway safe from any potential hazards.
Makes total sense. It's like a safety net for the respiratory system.
It really is. A stable airway and a clear path for life-saving ventilation thanks to the ETT.
Okay, so we've got the why down. Now let's dive into the what. Can you break down the anatomy of an ETT for us? What are we actually looking at with this little lifesaver?
Well, at its core, an ETT is a flexible tube with a beveled tip. And that bevel helps it slide in smoothly, kind of like a rounded door frame guiding you through.
So it's not just shoving a straight tube down there, huh?
Nope, definitely not. And near that bevel, you'll find something called the Murphy eye.
Murphy eye. What's that?
Basically a tiny little hole that acts as a backup ventilation route just in case that main opening gets blocked.
Wait, a backup system for breathing? That's pretty ingenious.
Right. It helps ensure a continuous flow of air, even if there's a kink in the tube or something blocking the tip.
Wow, I'm already impressed by the level of detail they put into this.
Well, there's a reason why ETTs are so important in healthcare. Might look simple at first glance, but every little detail has a purpose.
Okay, so we've got the bevel and the Murphy eye. Now, what about the cuff? That's always mentioned in textbooks, but I'm not totally clear on what it does.
So the cuff, think of it like a tiny balloon. It sits inside the trachea surrounding the ETT, and when you inflate it, it creates this seal to prevent air from escaping around the tube.
Oh, like a gasket. It keeps everything airtight.
Exactly. And that seal is super important. First, it makes sure all that air delivered by the ventilator actually reaches the lungs. And second, it prevents things like stomach contents or saliva from getting aspirated into the lungs.
Right, because if air is leaking out around the tube, the ventilator won't work as well. And aspiration, that's a whole other set of problems we want to avoid.
Absolutely. So maintaining proper cuff pressure is crucial for everything to work correctly and keep the patient safe.
Okay, but how do we know if the cuff pressure is just right? Do we need x-ray vision or something?
Luckily, no x-ray vision needed. That's what the pilot balloon is for.
Pilot balloon?
Yeah. It's this small inflatable bulb connected to the cuff by a thin tube. You can actually feel the firmness of the pilot balloon to gauge the pressure inside the cuff.
Oh, so it's like a built-in pressure gauge. That's pretty smart.
It is. Allows you to check the cuff pressure without doing anything invasive. You can even adjust the pressure by adding or removing a bit of air from the pilot balloon.
That's incredible. So we've got the bevel for smooth insertion, the Murphy eye as backup, the cuff for sealing, and the pilot balloon to keep tabs on the pressure. It's like the Swiss Army knife of airway management.
It really is. It just goes to show how vital airway management is. Each little component plays a crucial role in making sure the patient can breathe.
I'm telling you, this is so much more interesting than just reading about ETTs in a textbook.
Glad to hear it. We aim to bring these concepts to life.
You're doing a great job. Now, I know we've been laser focused on the ETT itself, but there's another MVP in airway management. We can't ignore the mechanical ventilator.
Ah, yes. Often called the lungs of the ICU.
I love that. So what exactly does a ventilator do? Break it down for us.
At its core, a ventilator breathes for the patient when they can't do it effectively on their own. It's a pretty sophisticated machine.
So basically, it's like a mechanical lung taking over the work of breathing.
Exactly. It delivers a controlled mix of air and oxygen to the lungs, making sure the patient gets enough ventilation and oxygenation.
Okay, so are all ventilators created equal? Or are there different types we should be aware of?
That's a great question. There are actually quite a few different types of ventilators out there, each with their own quirks and uses. And for you nursing students, it's super helpful to have a grasp on the different categories.
Perfect. Let's hear about them. What are the main types of ventilators we'll likely see in the hospital?
Well, we'll start with the most common ones, the volume cycled ventilators and the pressure cycled ventilators.
All right, let's unpack those a bit. Volume cycled. That sounds pretty self-explanatory.
It is. A volume cycled ventilator delivers a preset volume of air with each breath. Think of it like filling a glass of water to a specific line.
So it's all about consistency, delivering that precise dose of air.
You got it. This type of ventilator is really common when you need tight control over the tidal volume, like, say, in patients with ARDS or other acute respiratory issues.
Makes sense. Now, what about those pressure cycled ventilators? Are they more like inflating a balloon to a certain pressure?
You're exactly right. A pressure cycled ventilator delivers air until a preset pressure is reached inside the lungs. It's a bit gentler and allows for some variation in the tidal volume.
So it kind of adapts to how stiff or flexible the patient's lungs are.
Precisely. That's why it's often preferred for patients whose lung conditions might be less stable, as it helps avoid overinflating them.
Interesting. It's like finding that Goldilocks zone, enough air, but not too much.
It's all about finding the right balance. Choosing the right ventilator and settings is a huge part of airway management. Requires a deep understanding of the patient's condition, how their lungs are working, and what each ventilator can do.
So we've covered those volume cycled and pressure cycled ventilators. Are there any other types out there we should know about, especially as nursing students?
Yeah, there's actually one more category. It's becoming more and more common these days, especially for specific types of patients. We call it non-invasive ventilation.
Non-invasive. Okay, that sounds a lot less intimidating than those big old machines we see in the ICU.
It is. Non-invasive ventilation, or NIV for short, delivers breathing support without needing an ETT. Think of those CPAP or BiPAP machines people use for sleep apnea.
Oh yeah, I've seen those in commercials. You mean those can be used in the hospital too?
Absolutely. NIV is a super useful tool for patients with things like COPD exacerbations, heart failure, even some types of pneumonia.
So it's kind of like a middle ground
Yeah.
between breathing on your own and needing full-on ventilator support.
Exactly. It provides that extra pressure to help them breathe better, but without all the risks and complications that come with intubation.
That's pretty amazing. So we've got our volume cycled, pressure cycled, and now non-invasive ventilation. Sounds like there's a ventilator for almost every situation, huh?
There really is a wide range of options available, and picking the right one, it's a team effort. Got to consider the patient's individual needs and what's going on with their breathing.
Makes sense. Now, I have to admit, looking at those ventilators, they can feel a bit like spaceships at first, all those buttons and screens and settings. It's a bit overwhelming.
Totally understandable. It does take time and practice to get comfortable with all that. But let's try to demystify some of those essential settings you'll see as nursing students.
Okay, that sounds less scary. So what are some key settings we should be familiar with?
We'll start with something called tidal volume. Basically, it's the amount of air delivered with each breath. Think of it like the size of each breath.
Makes sense. So is there like an ideal tidal volume that works for everyone?
Not quite. You've got to tailor the tidal volume to the specific patient, considering their size, their lung condition, and what the overall goals are.
So it's not a one-size-fits-all kind of thing.
Definitely not. Then we have the respiratory rate, which is, as you might guess, the number of breaths delivered per minute. It's like setting the pace of breathing.
So if someone needs more help breathing, we'd increase the respiratory rate.
Bingo. And then there's FiO2. Stands for Fraction of inspired oxygen. It's the percentage of oxygen being delivered.
So normal room air is about 21% oxygen, right? If we increase the FiO2, we're giving them more concentrated oxygen.
Exactly, like turning up the oxygen dial.
I'm starting to see how all these settings work together to support breathing.
It's all connected. And keep in mind, those are just a few of the basic settings. As you go further in your nursing education, you'll dive into more advanced settings and even different modes of ventilation.
Okay, I'm definitely taking notes. Now, I know we briefly mentioned ventilator modes before, but I think it's worth revisiting them now, especially now that we've talked about those basic settings. Can you remind us what those modes are all about?
Sure. Ventilator modes basically control how the ventilator interacts with the patient's own breathing efforts, like choosing different levels of assistance.
Ah, that's a good way to put it. So what are some of the common modes we're likely to see?
One you'll see all the time is assist control, or AC mode. In this mode, the ventilator delivers a breath every time the patient tries to take a breath. It ensures a steady respiratory rate and tidal volume.
So it's like having a backup singer who always hits the right note, keeping everything in sync.
Perfect analogy. It's a great way to give full support for patients who just can't breathe well enough on their own.
Now, what about SIMV? I remember that one being a little harder to wrap my head around.
SIMV stands for Synchronized Intermittent Mandatory Ventilation. Yeah, it's a mouthful and a little more complex. It delivers a set number of breaths per minute, but it also lets the patient take their own breaths in between those set breaths.
So it's kind of training wheels, letting them practice breathing on their own, but still having that safety net?
Exactly. We often use SEMV as a weaning mode. Helps them gradually transition back to breathing completely on their own.
Okay, that makes way more sense now. And lastly, there's pressure support ventilation, or PSV.
Right. PSV adds a little boost of pressure with each breath, making it easier for the patient to overcome any resistance in their airways and just breathe more comfortably.
So it's like a gentle nudge helping them along.
Exactly. It's often used with SMV, or sometimes on its own, to support patients who are starting to do more of the breathing work themselves.
This is really starting to click for me. It's like all the pieces of the puzzle are finally coming together.
I love that. It does take time and experience to really grasp all the nuances of ventilator management, but I promise, with practice, it'll feel like second nature.
Okay, so we've got ventilator types, basic settings, and those modes down. What else is super important for us nursing students to know about ventilators?
I'd say one of the most crucial things is knowing how to spot complications.
Complications. You mean things can still go wrong even with all this fancy technology?
Of course. Even with the best equipment and the best care, there are always risks when you're dealing with mechanical ventilation.
Okay, so what are some red flags we should be looking out for?
One of the biggest worries is something called ventilator-associated pneumonia, or VAP.
VAP. That sounds serious.
It can be. Basically, it's an infection that develops in the lungs while a patient is on a ventilator.
So how do we prevent that? Is it just bad luck, or are there things we nurses can do to reduce the chances of VAP?
Prevention is key, and honestly, nurses play a huge role in making sure that happens.
Okay, I like the sound of that. So what can we do? Give us the rundown.
One of the simplest but most effective things is elevating the head of the bed.
Really? Just tilting the bed up can make a difference.
It does. It helps keep those oral secretions from pooling in the back of the throat, which could potentially drip down into the lungs.
So we're using gravity to our advantage.
Exactly. And then meticulous oral care is super important. Think of it like cleaning a wound, but in the mouth. Getting rid of bacteria and plaque helps cut down that risk of infection.
So it's like giving those teeth a VIP spa treatment.
You got it. Of course, good old hand hygiene is still the foundation of everything. Always got to wash those germs away.
Absolutely.
And then finally, careful suctioning technique. We need to clear out those secretions, but we got to do it gently so we don't introduce bacteria or damage the airway.
Right, that balancing act. Again, clearing things out, but being gentle with the lungs.
You've got it. Preventing VAP really is a team effort, and nurses are right on the front lines of that fight.
Okay, this is all great info. I feel way more prepared to face those ventilators now.
That's the goal. But remember, airway management isn't just about ETTs and ventilators. We've got one more important intervention to talk about: tracheostomies.
Okay, tracheostomies. Those seem a little more intense.
Right,
They can be. Basically, a tracheostomy means creating a surgical opening in the trachea, that's the windpipe, and putting in a tracheostomy tube.
So it's like a direct route for air to get into the lungs, bypassing the mouth and nose.
You got it. Tracheostomies are often used when someone needs long-term airway support, Maybe they can't breathe well enough on their own, or they need protection from aspirating stuff into their lungs.
So it's a more permanent solution compared to an ETT, which is usually temporary.
It can be. Tracheostomies can be temporary or permanent depending on what's going on with the patient and their overall prognosis.
Makes sense. So what kind of situations would make someone need a tracheostomy? What are some common reasons for doing that procedure?
Well, one big reason is prolonged mechanical ventilation. If a patient needs help breathing for a long time, a tracheostomy might be the best way to provide a more comfortable and stable airway. So instead of having that ETT in for weeks or months, a tracheostomy offers a better long-term solution.
Exactly. It also makes things like oral care and communication easier, which can be really challenging with an ETT in place.
Yeah, that makes sense. Are there any other reasons why a tracheostomy might be necessary?
Another common reason is when there's some kind of airway obstruction, like if a patient has a tumor, swelling, or an injury that's blocking their airway, a tracheostomy can bypass that blockage and give air a clear path.
It's like that detour we talked about earlier, but for air going around the roadblock.
You got it. And then there are certain conditions like neuromuscular diseases, things like ALS, where the muscles that control breathing get weak and don't work as well.
So a tracheostomy can help them get the breathing support they need.
Exactly. In these cases, it can really be life-saving.
Okay, tracheostomies are clearly super important, but I'm guessing there's some challenges that come with them too, right?
Definitely. Taking care of a patient with a tracheostomy requires a specific set of skills.
So what are some key things nurses need to know about caring for tracheostomy patients?
One of the biggest things is keeping that airway open. Unlike ETTs, which have a cuff to seal things off, tracheostomy tubes often don't have cuffs, or the cuffs are deflated.
So does that mean there's a higher chance of stuff getting to the airway and blocking it?
Yeah, exactly. So regular suctioning is crucial. Got to keep those mucus and secretions from building up and blocking the tube.
Okay, so suctioning is our best friend when it comes to tracheostomy care.
For sure. But we got to be careful and use the right technique so we don't hurt those delicate tissues in the trachea.
I'm noticing a pattern here. Effectiveness and gentleness are key.
Exactly. And along with suctioning, we have stoma care. That's super important to prevent infections. The stoma is that opening in the neck where the tube goes in.
So it's like an open wound, basically, that needs special attention.
You got it. We want to keep the stoma clean and dry to stop bacteria from getting in and causing an infection.
Okay, so what does good stoma care look like? What do we actually do?
Usually involves cleaning the skin around the stoma with sterile saline or a specific solution the doctor orders. Then we apply a sterile dressing to protect the area.
So kind of like taking care of a surgical incision.
You're right. And just like with any wound, we're always watching for any signs of infection. Redness, swelling, drainage, or if the patient's in pain.
Okay, so suctioning, stoma care. Got it. What else do we need to keep in mind when we're caring for someone with a tracheostomy?
Another big thing is communication. A tracheostomy can make it hard or even impossible for the patient to talk. So we need to find other ways for them to communicate.
Right, because if they try to talk, the air is just going to come out of the tracheostomy tube, not their mouth.
Exactly. So we might use things like communication boards, picture cards, writing pads, or even electronic devices. Anything that helps them express themselves and tell us what they need.
Got to get creative and figure out what works best for each person.
Absolutely. And beyond all the technical stuff, we can't forget about how a tracheostomy affects the patient emotionally and socially.
Right, it's a huge adjustment for them and their families too.
Definitely. Imagine not being able to talk or eat normally. It can be really isolating and frustrating.
I can only imagine. So providing emotional support and encouragement is just as important as the physical care.
It really is. We need to be patient, understanding, and listen to their concerns. Validate how they're feeling and help them adapt to this new way of life.
It's all about treating the whole person, not just a tracheostomy.
Couldn't have said it better myself. Trachea is complex, got a lot of layers, but it's incredibly rewarding.
This has been so insightful. I feel like I'm finally getting a grasp on how much goes into airway management.
That's fantastic to hear.
Now, I know we've covered a ton of information already, but there's one last piece of the puzzle we got to talk about, those dreaded ventilator alarms. All right, future nurses, it's time to face the music. Ventilator alarms.
Oh yeah, those can definitely get your heart racing.
It's like that pop quiz you weren't quite ready for.
I think every nurse, even the seasoned ones, gets a little jolt when those alarms go off. But it's important to remember They're designed to be attention-grabbing for a reason.
Right, they're not just trying to scare us.
Exactly. They're there to alert us to potential problems so we can jump in and fix things quickly.
Okay, so instead of panicking, we need to channel our inner Sherlock Holmes and figure out what's going on. Can we break down some of the most common alarms we might run into as nursing students?
Absolutely. Let's start with that high pressure alarm.
Okay, high pressure, that usually means there's some resistance to the airflow, right?
You got it, like trying to blow air through a straw that's got something stuck in it.
And we talked about the mnemonic BLOCK before, right? To help remember the causes.
That's right. Biting, liquid, obstruction, copious secretions, and kink.
Okay, so if that high pressure alarm goes off, what's our first move?
First things first. Assess the patient. Always.
Safety first. Right. Check on the patient before we start messing with the machine.
Exactly. Are they having trouble breathing, anxious, agitated,
Right.
any changes in their vital signs?
Okay, so if the patient seems okay, then we can move on to checking the ventilator and the tubing.
Right. Look for any obvious kinks or blockages. Is the tubing connected properly? Is there water or condensation built up that needs to be drained?
So it's like a systematic checklist, working our way through all the possibilities.
Exactly. And if everything looks good on the outside, then the problem might be further down inside the patient's airway. Could be a mucus plug, or maybe they're having a bronchospasm.
And that's when our awesome suctioning skills come into play.
Exactly. But remember, gentle and controlled. We don't want to make things worse by causing more irritation.
Right, that balance, again, clearing things out, but being gentle on the lungs. Okay, what about low pressure alarms? What usually causes those?
Low pressure usually means there's a leak somewhere in the system.
A leak?
Yeah, like a tiny hole in a tire. Air is escaping where it shouldn't be.
Okay, and the common culprits are a disconnected tube, a cuff leak, or a problem with the ventilator circuit itself, right?
You're in a roll today.
Haha, thanks. So just like with the high pressure alarm, we always start by checking on the patient first.
Always. Make sure they're breathing okay, their oxygen saturation is good.
Patient first, then we become leak detectives.
Exactly. Start by tracing the ventilator circuit, from the machine all the way to the patient. Make sure all the connections are tight, the tubing is intact.
Looking for loose connections, any visible damage. Got it. What if everything looks fine there?
Then zero in on the cuff. Check that pilot balloon. Is it firm, which means a good seal, or is it soft, which could mean a leak?
The pilot balloon, our trusty pressure gauge. So if the cuff is leaking, that means air isn't getting to the lungs effectively, and there's a higher chance of aspiration.
Exactly. If you suspect a cuff leak, you might need to adjust the pressure, or maybe even change out the entire ETT.
Okay, so we've checked the tubing, the cuff. What if we still can't find the source of the leak? Where else could it be hiding?
Well, then it's time to take a closer look at the ventilator circuit itself. There might be a loose connection somewhere we missed, a valve that's not working right, or even a tiny tear in the tubing.
That sounds like it could get pretty technical.
It can. As nursing students, you probably won't be expected to troubleshoot the entire ventilator circuit on your own, but it's good to have a basic understanding of how it all works.
Right. Knowledge is power.
And always remember, if you're ever unsure about something, just ask. There's always a more experienced nurse or a respiratory therapist who can help guide you.
Teamwork makes the dream work. Now, before we finish up our deep dive into airway management, is there one key thing you want our listeners to remember about ventilator alarms? What's the most important takeaway?
I think the biggest thing is to stay calm and approach them systematically. I know those alarms can be intimidating, but they're really there to help us.
They're like those little beeps and boops that are actually our friends.
Exactly. So take a deep breath, trust your training, and use your assessment skills to figure out what's going on.
Well, future nurses, we've climbed a mountain of information today. We explored endotracheal tubes inside and out, navigated the world of mechanical ventilation, and even tackled the complexities of tracheostomy care.
And we faced those sometimes scary ventilator alarms head on, learning how to troubleshoot like pros.
I have to say, I feel so much more prepared to walk into the clinical setting and face those airway challenges, don't you?
I do. But remember, this is just the beginning of your journey into this fascinating world of airway management. There's always something new to learn, and I encourage you to never stop being curious. Keep asking questions, keep seeking knowledge.
And never underestimate the power of a deep breath.
Well said. Thanks for joining us on this deep dive into airway management. Until next time, keep learning, keep growing, and keep breathing.
See you all on our next deep dive.